Hi, everybody. My name is Roberta Heel. I'm a nurse practitioner and owner of the virtual menopause clinic, which serves women across Ontario and Alberta for virtual appointments. I also have continuing education and patient education resources. But today we're here to talk to Carolyn Marshall about her work. So, hello, Carolyn.
Hey,
Why don't you
Roberta.
tell everybody what you do and then we'll get started.
Awesome. My name's Carolyn Marshall. I own a business in Sudbury, Ontario called the Mama Coach. And I am an experienced registered nurse. I've been an RN for 13 years, and I am also a Menopause Society certified practitioner. I offer perimenopause and menopausal consultations and support to women in Ontario virtually and in-home in Sudbury as well.
Excellent. So today you're going to help us out by talking about some menopause myths. Um, this has to be talked about. My goodness, there's so much information on the internet and family and friends, and it's hard to know what's real and what isn't. So let's dive into this a little bit. And what are some of the common myths you hear about menopause, and why do they persist?
So we do see a lot of myths, and they do come from historical underrepresentation of women's health, and that happens in research and medical education. The most common myths that I still hear frequently is menopause only starts when your period stops, that HRT or hormone replacement therapy is dangerous or only for severe cases. And I would like to highlight that myth started in 2002. It is 2025, so that would be 23 years ago. And then the last one is women must deal with their symptoms naturally. So a lot of these myths pursue due to outdated studies. There's been a lot of media misrepresentation, and then there's tons of gaps in provider knowledge. So one of the things I like to highlight with many of my clients is specifically in the gaps in provider knowledge is that I was offered a ton of training with the Mama Coach regarding menopause. And one of our speakers that presented to us was from Oxford University in the UK. She was the chief in her medical school running the obstetrics program, so obstetrics and gynecology, which would really be the specialist who is responsible for women's reproductive systems, including our ovaries, which are responsible for menopause. And despite her full research focus being about menopause and the chief of that program, she still highlighted a huge gap in the curriculum that physicians are still getting to this day, even at Oxford, that they learn little to nothing about menopause, and those are the specialists. So imagine how much less primary care health practitioners get, like family doctors, nurse practitioners, or registered nurses. So that gap in provider knowledge is really increasing the knowledge gap between patients and providers.
Absolutely. I've taught NPs for 23 years, and I belong to the Canadian Menopause Society, where I'm in collaboration with a lot of physicians and pharmacists, etc. And we all say the same thing. We don't have education about menopause. It's alarming, and it's unfortunate because it leaves women to find out information for themselves. So, is it true that menopause symptoms only start after a woman stops having periods? And why is this a misconception?
I'm so glad you asked that. That is definitely super hot right now. And that is because women are finally speaking out about how they're feeling symptoms before their periods stop. And we call this part of the transition perimenopause. So it's important to note that symptoms can actually begin 7 to 10 years before we hit menopause. And when we're speaking about menopause, I think it's a good idea to define what menopause really is. It's actually only one day. It's the day that you went 12 months without getting a period, assuming you still have all your parts. So you have your uterus and your ovaries. And I think it's important to note that it is still normal to even hit menopause or have that day without 12 months without having your period as early as 45. That's still considered normal. So if we back up that we can have symptoms 7 to 10 years before menopause, and it's normal to start as early as 45, that means women can start feeling symptoms of perimenopause as early as 35, and that still be completely normal. Now, why this is like a bit of a misconception is that we do see hormonal fluctuations, and that's actually causing the symptoms. So it's that we're having like the right amount of estrogen, and then we're deficient, and then we have the right amount, and then we have deficient, and maybe that happens for a couple of months. That sort of imbalance and that fluctuation happens while your periods continue, and that can feel really disconcerting when you don't know what's happening to your body. So there's a multitude, there's a huge list of symptoms. I do want to just kind of highlight the main ones. And those are the ones that we see as early signs are usually mood swings, hot flashes, brain fog, and sleep issues.
Oh my goodness, absolutely. So many of the patients that I see have those issues and haven't had a change in their cycles. So there's definitely something going on, but they're continuing to have regular cycles. So they're a little confused what's going on. Having said this, then, can you explain why lab work isn't always reliable in diagnosing perimenopause?
I do still hear this frequently with my patients that their family doctor, who may just not know what the current evidence says, and they recommend, like, well, let's go test your hormones, is usually how it's offered to
Yeah.
see if you're getting close to menopause. There are some specific hormones that we do notice increase or decrease when you're in menopause, but because perimenopause has fluctuations, that means that the lab results are only that snapshot of where you are that day at that particular time period. So if your ovaries have decided to function appropriately that day, we're not going to see any changes in your hormones. So it really isn't, there's no value into the patient or to the provider. If they did see that hormone that day, that your hormones were really low, it doesn't mean that they're not normal again the next day. So again, we're just highlighting that snapshot of time that maybe not representing where your body is, and there is no value, and the protocols and recommendations don't actually encourage us to do that blood work. The part that we do want to focus on, so we don't need the lab work to say you're in perimenopause, nor is it accurate. The diagnosis should really follow on your symptoms and your history. So there are some ways me and Roberta have been discussing, there's not a lot of literature around women's health research. So the main way that we can assess where you are in the transitional period is using a validated tool called the straw minus 10. And that helps us focus on where your symptoms are, what kind of changes you're experiencing, but it's only valid for people who have all their parts. So you have your history, you have your uterus, you've got your ovaries, and that you've had regular periods in your life. So if you haven't had those, it's not valuable, but we still want you to let us know what your symptoms are. That is an extremely valuable part of our assessment. The other part is some of those conditions that I mentioned or those symptoms can also be caused by other things. So we don't also want to blame menopause for everything. So we want to rule out other conditions like thyroid dysfunction or anemia, vitamin D deficiency, and those can cause some of the problems that you're having. So addressing those basic physiological needs first, if that doesn't happen or there is nothing and everything is normal, then we can kind of go to that it's likely caused by perimenopause.
Oh my goodness, so true. I typically don't do lab work for hormones. There are maybe some circumstances where it might be warranted, but not to diagnose perimenopause. I absolutely treat symptoms and not cycles or lab work. So the lab work doesn't help with the treatment, and it doesn't help you monitor the treatment necessarily. So there's really it's not the first line. And I agree 100%. And people being more aware of symptoms is huge. And speaking of that, what are the most overlooked symptoms of perimenopause and why should women be aware of them?
So I think it's important to highlight those lesser known ones. We all think about like the hot flashes, the night sweats. We're hearing a little bit more about brain fog and mood swings. The lesser known symptoms are important as well. Sometimes we don't realize it's all related, or in a woman's head, we're thinking, well, it's only hot flashes. I'm fine. But really, there's like a multitude of other symptoms that have appeared that we have not connected, that they're all related. So those can look like ringing in your ears, burning tongue, Joint pain is a huge one, and a one that when I mention on my social media channels, I get so many comments on. We also see a lot of bladder changes. Now I work in two different kind of divisions. I work with maternal child patients, so women who are having babies and in that early postpartum period. And then I have a second part of my business where I do women's health. And a common myth that I'm constantly debunking with my prenatal patients is that it's not normal after you have babies, whether it's immediate or when you get into your 40s and 50s, to sneeze and pee or avoid trampolines. So it does usually mean we have bladder changes. So ruling some of this out, knowing it's not normal, we can think that it's like, oh, well, that's just something that happens as I get older. It is something we can address for you. So a lot of women don't associate these things with menopause, and it does lead to delayed care. And depending what kind of symptoms you're experiencing, now vasomotor symptoms are something that have like a specific time period. So we're talking about hot flashes and night sweats. Eventually they'll go away. Now, when we're looking at things like bladder changes, which falls under a different category of menopausal symptoms like genital urinary symptoms, we know these are chronic and they're progressive, which means they won't go away. So the longer you delay your care when you're experiencing these symptoms, the harder for it is to get us back to where you want to be. So what we are really wanting you to be aware of this is basically education empowers women to seek the right help. So you knowing what's happening in your body is basically why me and Roberta exist. We want you to know what's happening so you can make changes, so you can lead a quality life.
Oh my goodness, the quality of life is so important. I ask every patient what they hope to achieve, and I would say that the majority of the patients I see tell me that they want to improve their quality of life and feel like they used to feel. So that is, you've hit the nail on the head with that. But having said that, then why is it a myth that menopause is natural and that women just have to suffer through it?
I hate this one so much. I do often hear consistent dismissive responses from physicians when women are coming to their family doctors and they're maybe not understanding that these symptoms are really affecting their quality of life. Now, when we're looking at that, yes, menopause is natural, assuming that we go through menopause with our ovaries slowly kind of declining in function, which they are supposed to do. So, yes, that's a natural process. But when we have untreated menopause, it actually can really significantly impact your quality of life. And the part that seems to be the huge knowledge gap is that there's long-term health consequences if we do not treat it. The other little piece of that like natural part is sometimes people aren't aware that when we have surgically induced menopause, so that's when we have the hysterectomy with the oophorectomy, meaning I took out your uterus and your ovaries, or I have medically induced a menopause, like something like chemo kind of destroys my ovaries. Those women actually have much more severe symptoms because they go from 0 to 100. And those long-term health consequences are much more severe for them. So it's even if it is natural, we don't have to suffer. And if we have caused you to go into menopause by treating you in some way, it's extra important for you to receive care. Now, when we're looking at not treating your symptoms, we're actually increasing your risk for cardiovascular disease. The biggest one is osteoporosis. We can also see diabetes. There's also some like newer research showing possible connections with cognitive decline, those types of things. We know there's estrogen receptors all over our body, so thinking that it can affect my whole body. So what women need to know in terms of suffering is you don't have to, because there is relief possible. There are preventative strategies, and that includes things like lifestyle changes, tailored care to your specific body and your specific lifestyle. And then we also can add HRT or hormone replacement therapy.
Yes, and oh my goodness, it's so important for women to understand that there are treatment options for them. And even if you have a contraindication to estrogen and progesterone, there are options, more and more so. So don't hesitate to talk to your provider about them. But having said that, then the the biggest problem that we can run across these days, or in the past 20 some years, is the idea that hormone replacement therapy causes breast cancer. So, what's your take on that?
That is The one. That is the big one. And I kind of alluded to this earlier. Now, this myth rooted back to 2002. So 23 years ago. And that was kind of brought about by a large study that was done in the United States called run by the Women's Health Initiative. And this study, now that we can retrospectively look back, was very poorly designed. And the myth that it caused breast cancer came from a poorly designed study that also was interpreted incorrectly, that was not peer reviewed and was not published yet before we had media kind of pick up on it, and the misrepresentation kind of flew like wildfire. I think it's also important to note that the specific position that hormone replacement therapy causes breast cancer has been rescinded by the researchers and has been replaced with other statements. One of the most important ones is that it is highlighted as the most effective treatment for vasomotor symptoms. And I think that's an important one to highlight. So, new research does show HRT does not significantly increase this risk for most women, and it can actually decrease someone's risk in some cases. So, that research wasn't done properly. The media got a hold of it before it actually finished the entire process of regular scientific study. And that is significant. The media wants clicks and the media wants you to do these things. And I don't think they really realized the scope and how long this would play out. The other part of HRT that some people don't realize is there's two types of HRT. We can have systemic HRT. So that's when we ingest it through oral means, or we have it through transdermal, so on our skin. We can also have, and that has systemic, meaning it affects my whole body. We also have specific HRT that addresses more of the specific symptoms in our genital urinary tracts. So vaginal estrogen happens to be particularly safe, and it's very effective because it affects the local part, so the genital urinary symptoms. Sometimes we don't even know we can be on both. If I'm on systemic and I'm still feeling like my vagina is dry as the Sahara Desert, I probably also need the addition of vaginal estrogen. So vaginal estrogen actually is not absorbed into the bloodstream. It barely affects our serum levels or the part that's in our blood. So even in cases where it may be contraindicated for you to take a pill or put a patch on, it may be okay for you to have it vaginally, and in most cases it is. So it's really important we're looking on women's unique needs, your risks. You want to see someone who knows what they're talking about, and we want to know that you have a lot of options for HRT. The HRT that was studied is also not the one that we actually promote most of the time. Specifically, the progesterone has really changed. We do use a bioidentical progesterone, which has much better absorption. And 23 years ago, you can imagine that our drugs are different now. So your grandma's HRT is not now HRT. And I think it's really irresponsible that this myth continues to proliferate. There's an entire generation of women who are not offered HRT because of the timing of the study and the timing that they reached menopause. And I think one of the reasons I feel so passionate about this is my mom is in that generation. She's 68 years old. It's too late for her to start. We do have safety guidelines, and she missed out on all those benefits and had to suffer when we know that she didn't have to.
Oh, it's true. And I think there's a lot to be said. There's a lot to unpack with that research and how it was disseminated and how it just went crazy and took over the whole medical world. And at the same time, in 2023, so 2 years ago now, the USA released a drug that was the first non-hormonal drug for hot flashes. It acts on the area of the brain where when estrogen levels lower, release a chemical that then causes hot flashes. The disturbing part of this was it was known, that area of the brain was known and understood to cause hot flashes since 1993. So it took 30 years for a drug to be created. And, it speaks to how women are perceived, the things that impact our life and our quality of life and our bodily processes are like addressed. And it's just not okay. Because even if we had assumed, even if it had been true that HRT causes breast cancer, not, but if it had, you would think that there would have been a real resurgence to create a medication or a drug to help women that specifically for hot flashes, knowing that we knew where the location was in the brain that caused them. So anyway.
I'm so glad you brought that up. You can see that there aren't a lot of options non-hormonally. You saying that this is the first one that's been approved. And I think, if it was true that HRT caused breast cancer, there didn't really seem to be anybody looking for another response. And I think that's really what you're saying.
It just
I
entered
think
into a black hole of menopause care for 20 years. Yeah.
absolutely. And hot flashes specifically, I find particularly interesting. They are the most common symptom that women are bothered by, but they're kind of like made light of in society. It's not funny to all of a sudden, and we do call them hot flash, and there's quite a few menopause practitioners that really like to call them hot flushes instead, which I'm sure you've read. And they want to change that definition a little bit more because it's not just a flash, it lasts several minutes. It's an entire body experience. And when we think about it more like that, it's not funny. Imagining taking like extra clothes when you go somewhere, having to leave the room because you're sweating, and then now you're cold because you're all full of sweat, not wanting to go to sleep at night because you're going to wake up multiple times and have that broken sleep and feeling tired the next day. Those are not manageable symptoms, specifically also going on long term. So it does feel very much like it's been kind of put to the wayside, thinking like, oh, it's just like a few seconds of hot and it's funny. It's actually really affects women's quality of life.
Oh no, you have to be very tough. I have a fan everywhere I go and have for a while. And people made fun of me at work. And I'm like, that's nice. There are huge health implications for women. I'm so glad that you've talked about these myths because if women need to understand that this isn't just a phase of their life for a few years, this is long term. And what is their health going to be like in the future based on these changes now?
Absolutely. Thank you so much for that. I think the biggest, I would think like as a concluding statement for me too, that is something I try to tell, even when people are just like not sure if they want to work with me, I make sure everybody knows because they feel so passionate about it. There's no validated tool that tells us if your symptoms are severe enough to
Right.
need HRT or treatment. If your symptoms are severe enough that they're bothering you, that is enough.
Absolutely. Thank you so much.